Hi, good evening all, and thank you for joining this GPhC webinar where we've got a focus on online pharmacies. It's great to see so many of you joining us this evening. You'll notice because the numbers of people we're expecting and just to make sure we cover in all the kind of questions people may have. We just ask you to use the Q&A function if there are any questions. We're going to be keeping an eye on that as we go. And if not, we'll ensure we've got some time at the end to hopefully absorb any final questions you might have. So thank you for that. For those who haven't met me before, my name is Ros Gittins and I'm the Chief Pharmacy Officer here at the GPhC, and I'm joined this evening by kind of co-presenters, Hannah Fellows and Miriam Andrews, who work within our Fitness to Practice team, and I'll let them introduce themselves maybe when we get to their presentation, if that's okay. We're aiming to finish within the hour, all being well. And I just want to share with you, first of all, just a little bit of data and a bit of context as to why we felt it's important to do a session this evening around online. So in keeping with our new strategy that was recently launched, our strategic aim 1 is really around how we can better empower pharmacists, pharmacy technicians, and indeed pharmacy owners in order to help ensure that they're providing safe and effective pharmacy services and able to work in line with our standards. And we have also been looking at our data internally to make better use of the information available here within the GPhC, and thinking about how we can share some of this data to help inform and to support registrants and pharmacy owners to provide those services, really. And I thought it'd be useful just to share a little bit around some of the concerns and the information that we're receiving predominantly from the general public. About 70% or so of the concerns that are raised with us, that's where they come from. But actually and our concern numbers have continued to go up. And in the last quarter, so our most up-to-date data, we've actually identified that there's probably a relative minority number of concerns that come in that actually relate to the online setting. But there's some useful learning for us in there, in that when the concerns are coming about, they're typically relating to advertising, issues around service delivery, or the pharmacy systems that are being used. And when we look at it in comparison to bricks and mortar pharmacies, that we're finding that they may be seeing more issues around dispensing errors or customer services related. So I think it's useful sometimes to be able to share more effectively some of the things, the kind of themes and trends, if you like, of what we're actually seeing in practice. And I think one of the things it's important for us to really highlight, although we're doing a focus session around online this evening, we do also acknowledge the valuable contributions and options in terms of ways that people can access services that the online provision brings. But with it is risk, or a different type of risk than perhaps a more traditional bricks and mortar pharmacy. And when we were looking at some of the concerns that we've received, it also relates to weight management medication. And we saw a particular peak in this when we released our updated guidance, which I know colleagues Miriam and Hannah are going to touch on a bit later, that we produced earlier this year. And in relation specifically to medicines used for weight management, we found that it was actually other healthcare professionals reporting inappropriate prescribing by the pharmacy or by the pharmacist. Perhaps the consultation style wasn't appropriate, or prescribing in clinically inappropriate situations. We particularly found issues around advertising and price promotions, and we work really closely with other regulators, including the ASA, around things like online adverts. So in line with our strategic aim 2, which is very much around us focusing around how we work more effectively with other regulators, for example, it's a good way in which we're able to evidence that. In fact, you may be aware of some of the earlier this month, the ASA have published some of their outcomes as well. And sometimes actually when the concerns come in, they may not actually be for us. So it might be more appropriate for other regulators. For example, if it relates to a prescribing service that isn't being provided by the registered pharmacy, for example, maybe CQC in England, it may be more appropriate for us to refer that to. So again, just highlights with our new strategic aims, the sort of work that we're doing. So there have been a lot of changes here at the GPhC, particularly in the last year, to some of our systems and processes. As I said, we're having increasing concerns, so we're having to think about how we were able to effectively respond to that. And we've also made a lot of changes within inspection. Mostly it's been focused around internal processes, so the systems and how we work. And you may have seen that we started implementing them early this year. And as a result, we're already seeing the numbers of inspections we're doing notably going up. We're already at the highest number of inspections since pre-COVID times. And indeed, we're on track for continue to be the highest numbers of inspections we've actually ever done. And we have also had a real focus in the number of new pharmacies awaiting their first inspection, in that we have, it says 30 on this graph here. In fact, when I was looking at data in the last 24 hours, we're actually down to, I think it was 5. So we're really getting on top of our kind of performance and the work that we're doing. But one of the things that we introduced early this year was to prioritise the new pharmacies that were being registered, that we would inspect those within 6 months. And this is because some of the risk issues we were seeing, because we need to be proportionate and have a risk-based approach to the way in which we work to make better use of our finite resources. And we've identified that actually the online or distance selling pharmacies were less likely comparatively to be meeting our standards. So we inspect a variety of different premises, although the majority are kind of community really. So these are some examples of some other types. And as you'll notice, we found unfortunately that the online pharmacies were finding it more difficult to be able to meet our standards. So this is what is, again, thinking about, well, how can we best share and inform those that are providing these sort of services to mean that they're more able to consequently meet our standards. And indeed, when the concerns come in, sometimes they may trigger inspections, or occasionally may result in us in terms of our enforcement action. Also thinking about potentially fitness to practice and how we may go about approaching that. So we've had, as you may have seen on our website, we've had some outcomes now from some online cases, and there's some really valuable learning there perhaps that we wanted to be able to cascade. So at this point, it's probably appropriate for me to hand over to Hannah and Miriam. Thank you.
Thank you, Ros. Hello, my name is Hannah Fellows. I'm the Head of Professional Regulation within the enforcement team and Head of Legal. Myself and my colleague Miriam are going to take you through some examples of cases we've seen going through the process, through from the initial concern being raised with us through to hearing. So the purpose of the session really is to explain our approach, the way we investigate and charge these remote prescribing cases. We're going to also take you through some examples, some cases which have reached hearing, and as Ros said, we're going to sort of touch on the new guidance as well. So firstly, our approach. So when we started seeing these concerns raised with us about online prescribing, we first of all needed to understand what the regulatory concern was. So what was it about these cases that concerned us? We've also looked at the context, so what was happening at the time that the matters were raised with us, and we've also assessed the risk throughout, and we think about the volume and complexity of the number of cases that are coming into us and what that means and what that's telling us. So just firstly, to talk about some of the common regulatory concerns. So prescription is a prescription. So essentially, it shouldn't matter where that prescription is issued, whether it's in an online setting or whether it's in a GP practice, a bricks and mortar pharmacy, or wherever. But I think that what we started to notice with some of the concerns that were raised with us is the nature in which the prescriptions were being issued, and the online. What we saw was high-risk prescription-only medications being supplied by way of these systemically weak service models. So we found that there were high-volume, questionnaire-led models being used, and a very transactional approach to prescribing of these high-risk medications, and or medications which required monitoring. And we also found that there was often very little GP input or any contact with the person who ordinarily cared for that patient. So one of the other concerns, matters that concerned us, was those who were routinely working within these systemically weak models. So thereby sort of they were implicated in putting patients at risk of greater harm. The prescribing models we looked at, we often found didn't meet the basic requirements of that therapeutic consultation. And we were looking at the time, particularly when a number of cases started to come through in sort of 2018, and then more of a peak in 2020 with the COVID pandemic. We found that the models that were being used weren't adhering to the RPS competency framework in terms of a safe prescribing decision. Another thing that we noticed was that the prescribing services online were often embedded or tied to a pharmacy service. So we looked at the nature of those relationships, the decisions that were taken by those who were engaging in those financial relationships, to see what due diligence had been undertaken, etc. And the focus of the fitness to practice investigations into that prescribing was therefore twofold. So firstly, how the service operated and what the role was of the professional who was working within that setup. So as I said, there was sort of wider context that we were looking at. So the prescribing model itself, what did it look like? What was the questionnaire like? Often in the cases that we've taken forward through to hearing, there was no direct consultation whatsoever with the patient, or no ability to even to speak to the patient, no checking or verifying of the patient's history, no meaningful consent. And what I mean by that is that there wasn't any sort of two-way dialogue. We also found inherent weaknesses in some of the systems, whereby a patient could enter an answer. If the answer didn't give them the outcome they wanted, they could go back and change their answer, and then the systems themselves weren't sophisticated enough to pick up those changes in response. We've also found has been very little or no GP contact at all, or if there has been a GP contact, it's been significantly post the event of the prescribing decision being made and the medication being dispensed. So whilst the GP may well find out, it was often too late in some of the cases that we've seen. And so essentially, the prescribing we found in some of these cases was transactional. And we looked also in some of the cases at the way in which the timings of the prescriptions. So, for example, how long the time was between each prescribing decision, and in some cases we saw it was a matter of seconds, or certainly under sort of a few minutes for each prescribing decision, which indicated to us that these weren't sort of therapeutic discussions, or there was no proper consideration. So, and just a reminder, obviously, that, you know, from our perspective, pharmacies are healthcare settings and not just retail operations. So, additionally, we were, as I said, I've mentioned the RPS framework, competency framework, but we were also utilising the GPhC's own guidance at the time and GMC guidance to look at what the prescriber obligations were to prescribe safely. The governance matters are something we've looked at in great detail, because often concerns that were raised with us were as a result of harm that was caused to a patient, and initially the individual who is referred to us is often the prescriber themselves, or the organisation that they were working within. What we quite quickly established was that often there were we were needing to look at the governance system. So what models were the prescribing organisations using, and what were the SI and RP obligations in relation to that model? And lastly, just obviously the reason that the GPhC exists and is to protect patients. And so we, amongst other things, but we had to ensure that the patients were being treated fairly and properly. And what we were seeing is that quite often high-risk medications were being given to particularly vulnerable people. And sometimes what we do have as a response is that, well, the patient has a certain responsibility to be honest and truthful. But often what we see is that very vulnerable patients were utilising the weaknesses in these systems to get medication which they should not have had and which caused harm to them. And lastly, I just wanted to talk about, risk. So something we obviously do throughout our investigations is to risk assess cases. And as I've said, we would always look at the model being used by the pharmacy and assess whether it met the requirements of the RPS framework or not. If it didn't meet that, how far did it deviate from it? We would look at whether the prescribing service itself was regulated, whether in the UK by GPhC or the CQC, and also the individual prescribers. Who were they regulated by? Were they practitioners regulated by the GMC or the NMC, or were they based abroad? Because we also look obviously at the dispensing of these through these systems. We've looked at the frequency. So how often has the individual been working in the model? Is this somebody who set it up, or is this a PIP? And have they been routinely working in this systemically weak service model? What were the volumes? And additionally, whether the individual who we are investigating had raised any concerns or tried to mitigate the systemic risks in the model in any way. So it's not just enough to have tried to mitigate risks on a patient-by-patient basis. What did they raise concerns internally with the organisation that they were working for? So obviously that's relevant, particularly in fitness to practice cases, as they progress further to identify whether that person is still currently impaired by reason of the initial misconduct. And lastly, we looked at whether individuals were working within the scope of their practice, and were the medications that they were prescribing routinely actually ones that they were familiar with, the causes, the conditions that meant they were needed to prescribe for those. And also we looked at whether there had been patient harm. And just lastly, I just want to take you through an example of the type of case that we would see. This was a patient with a history of emotionally unstable personality disorder, complex pain syndrome, Asperger's, anxiety, suicidal ideation, escalating self-harm, dependence on opioids, benzodiazepines, alcohol, psychotic, and having psychotic episodes. So somebody who was clearly unwell was having very close treatment through mental health teams and specialist services. This individual was then able to source a range of medications online from April 2018 onwards, and very sadly died of a mixed toxicity of alcohol and overdose of codeine, aged just 30, a year later. And in this case, the GP had never been contacted, not once, by any of the prescribers or the dispensers. And the GP commented that with full access to medical notes, he or any other GP would never have prescribed anything that this individual had been able to source online. So I think it's just a really good example and a reminder of why we take this so seriously, and why many of these cases have progressed through the system. So I'm just going to hand over to my colleague Miriam now, who's going to talk a little bit more about some of the themes and the outcomes from the Fitness to Practice Committee.
Thanks, Hannah, and thank you everybody for coming to this presentation and for giving us the opportunity to explain to you some of the things that we've been seeing in Fitness to Practice. What I'm going to run through now is some of this, as Hannah said. Just to explain that my name is Miriam Andrews and I'm a principal lawyer in the Fitness to Practice Directorate. So I am part of the enforcement team. So we're looking at some of the themes and outcomes from the Fitness to Practice committees. So what we're referring to here is the committee that handles the most serious cases that come out at the other end. So not all our investigations end up in the Fitness to Practice committee stage. Some of them are closed earlier when we decide not to take any further action. They're not issues that we can necessarily prove. Some are closed at what is the investigation committee stage. We're looking here, and I'm just bringing to this presentation those cases that are the most serious, and a lot of the themes have already been touched on when Hannah talked about what we consider to be of concern to us as a regulator. So the two roles that I'm going to be looking at, the various different roles that obviously pharmacists can undertake. And initially, the first case is about a pharmacist independent prescriber, and we're seeing this a lot more in our case load. Is the professionalism of the prescribers coming under scrutiny themselves. And this is prescribers working within a model that they don't necessarily control. And so what we're looking here is at the professional responsibility of those individual pharmacist independent prescribers. And again, the issues that come to the fore are the high risk nature of the medicines that we see. We're talking about drugs liable to misuse or abuse, controlled drugs, including opiates and Z drugs, for example, things that might be habit forming or toxic in nature. And we talk also about the risk of the reach and the volume of online pharmacies. What you've got is a very distinct, a distinction between the reach of a community pharmacy and the reach of an online pharmacy. You could be accessing thousands of patients and processing prescriptions at a volume that is considerably more than a local community pharmacy. We also look at the speed and transactional nature of online pharmacy cases. This is where we're looking at how quickly decisions are made by prescribers, and you'll see in the slide that's going to be coming next, which is a real case in relation to a prescriber, and the time that is taken when we can look at the data to review even the online questionnaire is insufficient even to properly digest it. So we're looking at a high proportion that are reviewed under a minute, without which we've taken the view is insufficient even to properly digest the questionnaire. We've had individual patients exposed to risk of harm. Hannah's given you a real life example of one of the patients that was referred to us, just to explain how that patient harm can materialise. But we've had referrals from hospital trusts, relatives concerned about the ease of access of their loved ones to medicines that are causing them harm, where there's a risk of overdose, as in the example that Hannah gave. GPs concerned for their patients, where they've stopped prescribing opiates, but their patients continue to access them online. We've also had referrals from coroners who've unearthed how an individual accessed the medication that they used to take their own life, and identified online pharmacies for us. So these are where we get all different referrals, and also we also get obviously referrals from our inspection colleagues who identify patients. So, and again, the scope of practice is something that we look at, where it's obvious or the evidence suggests that the individuals are prescribing for medicines where they're not necessarily qualified to prescribe for. And we have seen cases where there's been a pressure in online pharmacy settings, particularly for individuals to pick up patients that they might not necessarily feel comfortable doing. So if we could have the next slide, Hannah, please, which is this is the case study of a PIP. This is a determination that is available on our website, but I'm not going to name the individual to single them out. But this is this person was a prolific prescriber for an online pharmacy and for 2 other online pharmacies, and there is an example there of the numbers that we were seeing, and she was at a particular pharmacy for only 10 months but managed to prescribe 35,824 high-risk prescriptions, and these included controlled drugs such as Z drugs and opioids. This was a questionnaire-based prescribing. Well, they were all questionnaire-based models, and the approach was considered to be one that was transactional as opposed to being patient-focused. There was very little effort to contact patients' GPs or to verify even ID for some of the patients. And then you can see a proportion, 79.3% of the prescriptions were approved within 1 minute. And in this particular case, the committee found that the vast majority of the medicines that were being prescribed were opiates and Z drugs, which are well known to be prone to abuse and are known to be addictive. And this particular registrant did so, prescribed these without properly reading through the patient questionnaires, and in one case admitting that there was one button, that is the bulk prescribe button on her computer, which could press to approve multiple prescriptions at once. So there was no effort to look into the background of any of the patients. And even in this case, there was data that was even available to her of previous prescriptions that had been supplied to an individual from that own online pharmacy that wasn't even being checked to look for red flags. So that was another issue. So most prescriptions were issued without GP contact. Registrants on some occasions weren't asked if they consented to GPs being contacted, but were prescribed nevertheless, notwithstanding that they'd been asked for consent, they were still prescribed the medicines that they had asked for. And so consent, it didn't matter because the GP wasn't contacted anyway. The committee remarked that the professional standards expected of her applied no matter what setting she was working in. So this is just to loop back to the point that Hannah made earlier about a prescription being in a prescription. And I've pulled out some of the quotes there that the committee said. The committee could not be alarmed at such conduct. Online settings are no different from face-to-face settings. By persistently failing to undertake proper reviews of patients seeking high-risk medications, she enabled patients who were suffering from issues with addiction and seeking to harm themselves to circumvent the highly regulated system of obtaining medication. And interestingly, in this case, the registrant described to the committee the steps that she would take, and she knew full well what she should have done in terms of before she prescribed to a patient, but failed to observe those standards that she observed in all of the 3 online pharmacies that she worked in. So this is a particularly poor example of, a good example of poor prescribing. She worked over a long period of time, and she was eventually removed from the register as a result. So this is a very serious case that ended up in removal. Not all cases end up in removal, but this one did particularly. And if you want to go to the next slide. So the next role I was going to look at was that of responsible pharmacists, superintendent pharmacists, and third-party dispensers. And just to, again, the high-risk nature of the medicines, but the difference and the reach and volume of the online pharmacies is the same with the PIPs. But what we've got here is a sort of a focus on the governance issues that we have, that we've tried to address in various pieces of guidance. And also is picked up by our inspection teams, where they see systemically weak setups. I know there was a question actually in relation to how we define systemically weak, and just it's a phrase that we use, but really we leverage quite often the judgments of our inspections teams, and it's where we don't have robust processes in place to safeguard patients. That's essentially what we're talking about here there. So that's just to answer that question. But and we're talking about lack of audits, risk assessments, and SOPs to mitigate the risks that we see with online pharmacy distance selling setups. In particular, where we're talking about a third-party dispenser, so we're not talking about particularly where we've got prescribers in the pharmacy itself. You might have a community pharmacy, for example, who is dispensing for an online pharmacy, and we have had a few cases now where we've got we've had a failure to undertake proper due diligence when it comes to entering into arrangements, whether it's contractual or otherwise, with third-party with those online prescribing services, and we've seen situations where maybe a prescribing service approaches a community pharmacy and says, "Oh, I've just got a backlog. Can you just help me deal with it?" And it's like, well, you'll get paid X amount per prescription, and it seems as an attractive option. But really, the new guidance, and we'll come to it again at the end, is about ensuring that due diligence and understanding that you are responsible for the SIs and the responsible pharmacists are responsible for the prescriptions that they dispense and how they have been prescribed. So understanding the background to that is important. So if you could just move on to the next slide, Hannah. The case study is again a real life case from a few months ago, actually. This was a pharmacist who was a director and a superintendent pharmacist and a regular responsible pharmacist at and he was a very experienced pharmacy owner at a pharmacy. And he had dispensed for a prescribing service. The prescribers were based overseas and were unregulated, so they were operating for an unregulated setup. And I say unregulated, I mean regulated in the UK. And the prescribers themselves were not regulated by a regulatory body in the UK either. They were inspected in 2018 and found to have not met a number of standards. And some of the observations from the inspectors were that there's no evidence of risk assessments to provide assurance that high-risk activities are being appropriately managed. This would include using non-UK regulated prescribers, supplying addictive medicines without the knowledge of agreement of the patient's GP, the patient entering incorrect information during the online consultation. So you've got prescribers primarily relying on information provided by patient in the online questionnaire to prescribe. But what you've got here is a bit more distance, insofar as it's not the pharmacy that the pharmacy owner owns that is doing the prescribing, but it's a relationship that they've entered into dispense for a pharmacy, for prescribers, or they've entered into a relationship with prescribers, and where they will do the dispensing. And so there were a number of issues with this particular pharmacist, but one of the ones that I've highlighted there is a failure to ensure that prescribers were following relevant GPhC and GMC guidance. So it's not just that they were regulated, it was that they weren't following that guidance that it was appropriate to any prescriber prescribing in the UK, and that includes GPhC, GMC, and Royal the RPS guidance. Any relevant guidance we take into account when considering the suitability of the prescribing. One thing that I was going to mention about this case, and I won't go on too much, but was about how the guidance can change over time, and there was some discussion in this committee hearing about how guidance can change, and I'm going to share with you, if you don't know it already, about how the latest version of the guidance, but how guidance can change, and guidance is not mandatory, not like the standards are mandatory. However, if a pharmacist has diverged from the guidance, which is what the committee commented on this, which they had the right to do in principle, the onus would then be on them to show how that divergence still safeguarded patients, because the basic responsibilities of pharmacy owners and of course superintendents, pharmacists had not changed, even if the guidance had changed. And the basic responsibilities being the culture and processes within the pharmacy deliver safe and effective care to patients and the public. And so, however that pharmacy service is delivered, the legal principles and regulatory standards aimed at guaranteeing safe outcomes for patients must still be met. So I pulled a quote there, and it says the registrant's failings went to the heart of the role of the superintendent and director of a pharmacy business. Whatever its nature, if running a pharmacy at a distance was inherently more risky than a traditional pharmacy, then it was down to the registrant to ensure his processes were sufficiently rigorous to maintain professional standards in the delivery of that pharmacy service. So that is just about making sure that due diligence is affected on when engaging with any third parties. And so that is just the different FTP outcomes that we're going to look at. Oh, that he was given an 8-month suspension order, by the way, not as serious an outcome as the PIP, but still quite a serious one. So yes, just to bring back to the updated GPhC guidance in relation to distance selling, I was just going to highlight a couple of the clarifications and additions that we've made to the most recent edition, which was published in January this year. And so it was to flag that in terms of two-way communication, there should always be a means to allow this between the patient and the prescriber. There should be an ability to independently verify information for high-risk medicines, and that's about not relying on a questionnaire alone. Weight management has been added. I think Ros mentioned as to why in the opening, but we've stipulated that you must be able to verify weight, height, and/or BMI as part of the prescribing of weight management medicines. We have said that there should be clinical records to include follow-up plans and medical history, and a rationale for that prescribing. And again, working with third-party prescribers, due diligence carried out to ensure prescribers have necessary safeguards, which we've already covered. Now, this isn't an attempt to, make you concerned about your practice, but simply to cover some of the things that we have seen and ensure that you're aware of the guidance that we've published on prescribing at a distance, and to bring it to your attention again. When we look at these things, we're looking at this when we're looking at the seriousness of what we're concerned with. We're looking at the scale of the prescribing, the types of medicines being prescribed, the role of the individual, as I've just covered, the length of time over which it's occurred, their level of experience, and the prescribing model within which they're operating. So I would point you to the most recent prescribing guidance, but that prescribing guidance also points to other prescribing guidance, which we also take into account, that of the GMC and the RPS, as I've just articulated, and just remembering the point that Hannah made earlier about a prescription being a prescription, a prescriber being a prescriber, patient safety, whatever the forum it's delivered in, patient safety has to be at the forefront. So I would encourage you, if you're interested in the guidance and you missed the webinar in January, to have a look on our website under previous events, and see if you can catch that, because it goes through the new guidance in more detail. And if you want, you should be easily able to find the new guidance, but if you can't, then get in contact. And that's it. Thank you from us. Anything I need to address that hasn't been addressed already?
Thank you, Miriam. Thank you, Hannah. And I also should have started from the outset of also acknowledging we had Kieran Jones also joining us this evening, who's our head of pharmacies regulation. So a particular big thanks to Kieran, who's been helping us field the kind of Q&A. I think we have been able to respond to all of the questions. I'm also mindful that this is a recorded session, so it could well be that those who are watching this in a playback later may not be able to see the questions that have been asked, but I think what I'd essentially kind of summarize the questions that have arisen around the slides. Yes, they will be made available, so we'll ensure we get this alongside the recording available, likely on our website as soon as we reasonably can. And there's been quite a few questions around reporting of concerns. So I mentioned earlier, sometimes things that come in to us, we're not the right regulator for them. So it might be that it's a regulated prescribing service that's not from a registered pharmacy premises. It could be relating to advertising, so things like ASA instead, or MHRA. There is a useful part of our website that has got further resources, and I know in response to one of those, Kieran's also kindly, for those able to access the Q&A at the moment, provided links to those as well. The guidance, as Miriam's articulated, is readily available on our website. That's the guidance, the online guidance that we updated earlier this year. Obviously, as has been outlined, there's been various reasons as to why we've done. We felt it was important to make certain things clearer, including around the information and access to information that's required. There's a lot of work that the GPhC here that we do behind the scenes, essentially, and I think we do need to get better at sharing that and talking about that, and that includes raising awareness and helping to flag why it's so important that pharmacy staff are able to appropriately access records regardless of where they're working, to ensure that they've got ready access to the information that they need. We've had some specific questions also in the Q&A relating to individual or indeed potentially live cases, which is why we haven't been able to answer some of those as fully as perhaps some would have liked. We have also had a question around acknowledging that we're going to have even more prescribers coming in the future, pharmacist prescribers, especially as those individuals are qualifying as prescribers, being prescribers when they first qualify as of next year, and that's why we are implementing a program of education sessions for MPharm. We're looking to do the same with OSPAP, and also for pharmacy technician training program resources as well. So we need to continue getting better at sharing about what we're doing, and hopefully it's just helped to raise awareness through that, and that education program that I've referenced starts with effect from September. And I'm just thinking if there are, I'm just double checking we've responded to all the other kind of questions. Just sorry, bear with me a second, just having a quick look through now. So there's also been a really good question around other regulators who've equally experienced issues around problems with weight loss medication specifically. So we do continue to work closely with those other regulators, and CQC is a good example of that. We and it's not just us meeting behind closed doors. We also meet with particularly with online providers, and the DICE network is a good example of how we're able to do that and disseminate some of the learning in a timely way, and we do that jointly as well. Okay. There's also been a useful question around our approach to regulation and how does that differ between bricks and mortar compared to kind of online. It doesn't matter what setup the pharmacy is, in that they still have to meet our standards. So we would very much be looking at, when we're undertaking those inspections, regardless of how they're configured, bearing in mind as well, some kind of more traditional bricks and mortar pharmacy, they may even have an online component to what they do. So we have the same set of standards, and obviously the sort of evidence we look for may vary, because it's got to be specific to the services and things that they're providing, and it's for them to evidence how they're working in line with our standards. Okay. I think, is that all of our, I think that's possibly all the questions that have come up. Oh, there's been a question from somebody else around email exchanges and video consultations. So we have provided more information in our updated guidance about how we undertake those, how we're expecting those consultations to be conducted. We've also got a supportive FAQ document that's also on our website, so that will be a useful resource perhaps to refer to. Okay. Unless from colleagues Hannah, Miriam, or indeed Kieran, is there anything else that, just double check in case I've missed it, or anything else you'd like to add? No.
Anything from me, Ross? No.
Fantastic. Well, thank you so much, everybody, for your time this evening. As I said, we'll ensure that the resources and this recording is also available online for you. So thank you so much. Bye-bye.